Sure, that's fine. Right. Hello and good afternoon, everyone. Welcome to the 33rd session of MRF HIV SCI ECHO. I am Dr. Gregory Boyce. I shall be your host and facilitator for this afternoon. We welcome you and thank you all for attending the session with us. With us today is Conrad Mitchell, again at distance, doing great work at home with his new puppy. And we welcome Dr. Edwards, who's our the other member of our expert panel, and we welcome all our guests who are with us this afternoon. We're going to get started today with the third in the series on opportunistic infections, and we're going to talk about tuberculosis, which is a pretty big topic. So I've broken it up into two. The first part of it is going to be more on things like the pathophysiology and
talk to you about what you read.
And the second session is going to be a bit more clinical. So the diagnosis, management, and chemoprophylaxis. So I'll just start that session. Give me just a bit. Let's hope the technology behaves itself. All right, can everyone see clearly?
Just waiting for it to come up, and it's up. Go ahead.
All right. So as I said, this is the third in the opportunistic infection series about tuberculosis, and this one will be about tuberculosis, epidemiology, pathogenesis, and screening. So this slide just as one of our business slide, just to say that this is not meant to be a substitute for professional medical advice, diagnosis, or treatment, and to acknowledge the tremendous support we've had in putting the ECHO program together with at University of Washington, ITech, and University of New Mexico. They are the brainchild behind the ECHO program. So I have no conflicts of interest or any disclosures to make. So we're just going to talk sort of 30,000 foot level about tuberculosis, what the global picture is of tuberculosis. So tuberculosis has been around for a long time. It's an old foe. There are records as far back as 4,000 years with, for example, with bone disease that we know is due to tuberculosis. And there's some experts who think tuberculosis might have entered the human population sometime around 70,000 years ago. It is and always has been a significant cause of human suffering. As many as 1 in 7 persons in Europe in the 16th and 17th centuries were afflicted with tuberculosis, and it affected an estimated 1/4 of the working population. So you just imagine that kind of number. The epicenter of tuberculosis has shifted since then to what we, I guess, call the developing world. So 8 countries now account for about 2/3 of the global tuberculosis burden. And those 8 countries are India, China, which would just be a population effect. 1% of a billion people is a lot of people. Indonesia, the Philippines, which was surprising, Pakistan, Bangladesh, and 2 countries in sub-Saharan Africa, Nigeria and South Africa. So in 2017, 1.5 million persons died from tuberculosis, including just over 250,000 persons living with HIV. And TB remains the leading cause of mortality among persons living with HIV worldwide, accounting for about 1/3 of deaths from complications of HIV. So in terms of what the picture looks like in Trinidad, this is from the 2016 situational analysis that was given on World TB Day a couple of years ago. So there were 234 total cases registered for the year 2016. They are at the chest doing a tremendous job getting everyone tested for HIV, so they're 100% response. And the prevalence of persons diagnosed with tuberculosis and co-infected with HIV was just about 19%. And we'll see how that compared with the rest of the region shortly. Most of those cases were pulmonary tuberculosis. None were extrapulmonary, which is surprising, because we should estimate about 10% of all persons who are diagnosed with HIV who are living with, who are diagnosed with tuberculosis and living with HIV should have extrapulmonary disease. So the question is, are we missing some of this extrapulmonary disease. There were 4 retreatment cases and only 2 deaths in 2016, which was a trend that actually started since 2011 and was really, really good, and showed the tremendous cooperation that we have and the good synergy we have with the TB treating team at Cora and Eric Williams. In terms of the geographical distribution, about 60% of all cases of tuberculosis are found in the St. George County, that's west, central, and east, and that may just be a population density issue. And it's about a scattering, of cases, in Caroni, Victoria, and the rest of the island. And the gender is predominantly male, right? So roughly 3-to-1 ratio male to female. And in terms of the ethnic distribution, again, primarily African descent, and that again may be a geographical thing rather than any other reason, given the geographical distribution of tuberculosis on the island. 72% African descent, 24% East Indian, and a small number of cases otherwise. And in terms of what the regional picture looks like, and this was drawn from the 2019 report, Guyana reported 500 cases with about 24.6% prevalence of HIV/TB co-infection. Jamaica, which is twice our population, has interestingly half the number of TB cases that we did. Barbados reported no cases in 2017, and I think only 1 case in 2018. Haiti has an overwhelming burden. I think it's probably one of the highest in the Caribbean, with over 15,000 cases, with 2,000 persons who are diagnosed with HIV and tuberculosis, with a prevalence rate of about 15.1. So if we were to speak briefly about, pathogenesis of tuberculosis. So when you think about tuberculosis, it's really what we call a Mycobacterium tuberculosis complex, the Mycobacterium tuberculosis organism, and about 7 related species: Mycobacterium vulvis, Mycobacterium africanum, Mycobacterium cateum, something like that. But Mycobacterium tuberculosis is the most common cause of TB in humans. And TB is spread via inhalation of infected aerosol particles, so those small 1 to 5 micron particles that are expelled from the respiratory tract, doing things like coughing, sneezing, singing, shouting, some even just speaking, especially in persons who have laryngeal disease, where there is a very high risk of infecting this with speech. A single cough can generate as many as 3,000 particles, and the infectious dose, the number of organisms enough to actually infect somebody with tuberculosis in one of those tiny droplets can be as few as 10. Experimental data actually said it could be as low as 1 to 3. Because those tiny particles, instead of being filtered out in the upper part of the airway, where, for example, they might deposit on the hairs of the nose or some of the immune mechanisms in the upper respiratory tract, and some of the commensal organisms, those bacterial organisms that normally invite a certain type of immune surveillance in the upper respiratory tract, coincidentally will sort of filter out tuberculosis as well. When those tiny particles are delivered deep down in the lower respiratory tract, these smaller ways in the alveoli, it attracts a slightly different type of macrophage that is not capable of killing tuberculosis as efficiently as some of the immune cells in the upper airway. And just a small note, tuberculosis is not spread via surface contact. And I think sometimes there's a bit of a panic when you hear about a case of tuberculosis, and let's say in a police station, in a workplace, they want everything sanitized and wiped down and bleached down. It is generally not spread that way, even though it's a reasonable precaution. There is no absolute need to panic in that regard. Now, the infected particles, because they're very small, they can remain suspended in air for hours. And if there is not, as for example in this room where it's central air conditioning and not a certain number of air chambers in a certain period of time, if someone with tuberculosis were to walk into this room and cough and then leave the room and then walk in half an hour later, there's no direct sunlight, to say ultraviolet light, that will kill the organism. It's synthetic light, the windows are closed, so there is a significant imperative, and we are kind of all learning this now by force due to COVID, the importance of proper ventilation of workplaces when there are patients who may be coming in with potentially infectious respiratory diseases. Because with tuberculosis, a lot of times, patients aren't aware they have tuberculosis. Right? They think it might be a bad cold, a bad flu. They go talk to their doctor, get some antibiotics. They didn't go away, go talk to another doctor, get some more antibiotics. And a lot of times, weeks to months will pass until an alert clinician will say, you know what, something's wrong. You have these symptoms for too long. Or the patient themselves may deteriorate to the point where they present at a tertiary healthcare facility and have a chest X-ray done and have the disease diagnosed that way. So as I alluded to previously, when the organism is deposited in the alveoli and the distal airways, it is engulfed by alveolar macrophages, which are certain types of white blood cells that remove pathogens from their vicinity. But in 50% of cases, the infection is contained at that level without spread. So the organism is destroyed, it's completely eradicated, and that's it. There's no further propagation of infection. But in 25 to 50% of cases, the organism is encapsulated within those macrophages, but the processes within those macrophages is sometimes insufficient to destroy the organism, and those macrophages migrate to regional lymph nodes in the chest. And at that point, when the immune response starts to ramp up, and you get what you call case necrosis, you can get which the lymph nodes start to degenerate into this sort of cheesy, which is where the caseous word comes from, sort of necrosis, and then it eventually heals with calcification, and that's what we call a gone complex. So sometimes you'll see someone with an X-ray, and those lymph nodes sort of scattered around close to where the heart is. You see this small calcification, and that may be evidence enough that that person was exposed to tuberculosis. Now, during that initial infectious phase, initial infection phase, only about 5% of cases present with symptoms of infection, because you would think, we have tuberculosis traveling through the lungs. Wouldn't the person have a fever? Wouldn't they have a cough? So there is something such as primary tuberculosis, which can sometimes manifest with symptoms like fever and coughing. And we'll get to that more in the second talk when I start talking more about the clinical manifestation, the clinical aspects of tuberculosis. But it's a minority of cases. Now, cellular immune responses are triggered by the presence of the tuberculosis organism, and that increases in intensity over the first 2 to 12 weeks. So during that period, that's the first time someone might actually have a positive immune-based test for tuberculosis. So what we know as a mantle test or a tuberculin skin test may not be positive, even though that person was exposed to tuberculosis 10 weeks ago. It may not turn positive right away, which is why screening immediately after an exposure and that person screens negative doesn't necessarily mean that that person has not in fact been exposed. It might mean that they haven't developed that immune response as yet, and nothing will turn up. That person should be rescreened. Now, once the organism is within the body, further dissemination via what we call the hematogenous spread, so via the bloodstream, can occur in the following 3 to 6 months. And this can, the organism can be carried to either different parts within the lung itself, or it can be transported to distant organs like the bone, the meninges, and that can cause TB meningitis, the kidneys or the adrenal glands, and so forth. Now, persons living with HIV have decreased CD4 and CD8. Now, CD4 cells are helper cells, CD8 cells are what are called natural killer cells. But independent of stage of HIV infection, persons living with HIV have reduced responses to tuberculosis antigens beginning early in the course of the disease. And this was found in a very interesting paper in 2007, where they actually stratified persons, about 40-something persons, based on CD4 count. So we expect someone who's living with HIV with a low CD4 count and with immunosuppression not to respond to tuberculosis antigens because immunocompromised. That isn't surprising. But what the study found was that even in persons with relatively preserved immune systems and CD4 counts above 350, that there was a blunting of that immune response to tuberculosis, which explains a couple of different things. One, the reason why persons with HIV have a much higher risk, sometimes 100 times higher risk of acquiring HIV infection throughout their lifetime. Second, that they are higher risk of the disease progression and dissemination, because if the immune system is not as active against tuberculosis antigens, it does a poorer job of containing the infection once the body has been presented with the infection. And thirdly, there are lower rates of TST or skin test reactivity. So it's not uncommon, and right now there are cases in hospital where persons have smear positive tuberculosis, so they have clear evidence of tuberculosis, everything else fits, they have good CD4 count, but their mantle test is zero, right? You do a screening test on them and nothing happens despite a relatively preserved immune system. And that intact cellular immunity is also responsible for the development of the cavities, the intrathoracic or lung cavities that we typically associate with tuberculosis. We think of tuberculosis as a cavitary disease, especially within the lung. That's a classic lesion. But because the formation of those cavities requires an intact cellular immune response, so normal CD4 and CD8 responses, we don't get those cavities as often or at all sometimes in persons with HIV, which, and again, in the talk I'll give next session, explains the difference in how TB presents clinically and radiologically in persons with HIV and persons without HIV. And those cavities are also responsible in significant part for the production of the organism in sputum. So if you don't have the cavities, you tend to have lower rates of smear positivity. So it makes TB diagnosis a bit more complicated in persons living with HIV, because it actually doesn't look typical for tuberculosis. The skin test can be negative, and the smear test can be negative. So it makes the diagnosis trickier in a condition that is important to diagnose early. Now, if infection is in fact contained, the infection enters what we call a latent phase or latent TB infection, with dormant tuberculosis organisms contained within infected what we call granulomatous lesions, which are almost like a nest of these multinucleated giant white blood cells encasing the organism. It's almost like a tiny prison in which they are dormant, but not yet inactive, in the sense that it's not destroyed, TB organisms. So that you have to think of the immune system like the prison guards that make sure this TB organism doesn't break out to jail. But as we get older, or if there's any other immunocompromising situations such as HIV infection, solid organ transplantation, steroids, diabetes, lots of other things that would cause a blunting of the immune response, those TB organisms can escape immune surveillance and reactivate locally. So you can get either reactivation tuberculosis within the lung or disseminate this to then get disseminated tuberculosis, which is why I tend to see sometimes on the TB wards older patients with tuberculosis, not because they got it at that age, but they may have gotten it 30 years ago or 20 years ago. And because their immune system is weakened with age and is now significantly weaker than it was when they were in their 20s and 30s and 40s, their immune systems are no longer able to contain the tuberculosis, and they can end up getting ill as a result. Now, HIV negative persons after initial exposure have a 10% lifetime risk of reactivation. Persons living with HIV have a 5 to 10% annual risk of reactivation of TB disease, which is a significant risk. Because every year, if you've been exposed to TB and you have latent TB organism, every year you have a 10% risk of reactivation of this disease. So we're going to talk a bit about screening. So how do we screen for tuberculosis? Well, the first step is clinical screening. So there was a study done whereby they, I think it was in a country in Vietnam and a couple of in Cambodia and so forth, 17,000 patients. They asked them whether or not they had, at every clinical encounter, symptoms, cough of any duration, fever of any duration, or night sweats lasting 3 or more weeks in the preceding month. And that just those questions was 93% sensitive, picking up tuberculosis, which outperforms the sensitivity for a lot of the other testing modalities we're going to discuss. The only issue is it was not as specific. So it would detect tuberculosis if it's there, but it might also detect some other infectious disease. It might detect malaria, it might detect lymphoma B symptoms, because you might get some respiratory involvement, fever, and night sweats. Right? But it would pick up tuberculosis. Right? And it's simple, doesn't cost a thing, but other than the time you take to ask the questions. So the presence of any of those symptoms, fever, cough, or night sweats, had about a 1 in 5 positive predictive value. But the absence of these symptoms, meaning if you had no cough, no fever, no night sweats, you had a 97% chance of not having tuberculosis. Right? Now, yes to any of those questions, especially in a community of immunocompromised persons, should prompt further investigation and management, possibly. So, for example, someone comes in and tells you they had on and off night sweats for a couple of weeks and this kind of tickling cough, but doc, I think it's my sinus, and it's the Sahara dust. It should prompt an evaluation, because TB can manifest in very different ways in different people. Right? So you don't have to have the classic purulent sputum with blood and chest pain and night sweats and losing weight. It can present in so many different ways. So the other screening modality that a lot of clinicians and even patients are accustomed to is this tuberculosis skin test, or TST, or MAN2 test that we're accustomed to. So it's 10 tuberculin units injected intradermally, not subcutaneously. That's a mistake I made earlier in my training. It's just into the skin, right? And in duration, not erythema is assessed and measured with a ruler after 48 to 72 hours. It's not what you see, it's what you feel, right? You feel for the swelling. So any zone of swelling it's measured along the length of the arm, parallel to the length of the arm. More than 5 millimeters is considered a reactive result in persons with HIV, immunocompromised persons, or persons with suspicious X-ray findings. So, for example, you're evaluating someone with maybe some cough and some weight loss, and they have some shadow in the upper part of their chest, but its skin test is just 5 millimeters. That's enough to be considered reactive, right? If the reaction is a 10 millimeter or more reaction is considered reactive in immigrants from high prevalence countries, recent immigrants, right? Residents or employees in high-risk settings, microbacteriology lab technicians, so not just any old lab tech, someone who's involved in handling and processing of tuberculosis samples, persons who inject drugs, children less than 4 years of age, and adolescents, teenagers, children, all the way down to 2 years old, who are exposed to high-risk adults. And any reaction 50 millimeters or more, regardless of risk category, whether you live with HIV or not, that is considered positive. Right? So what are some of the limitations of the tuberculin skin test? So it's subjective, and that can sometimes be tricky. So you're relying on someone to sort of poke around and feel for the swelling and get the ruler and measure the swelling. And in some of those borderline cases where it's like, well, is this 10 or is this 7? Is this positive or is this negative? It is subjective, right? And in the performance of it is also subjective as well, that it is independent on the skill of the person and the experience of the person who's doing the investigation, who's performing the test, and the quality of the instructions you give the person. So you don't itch it, you don't rub it, don't put anything on it. It requires a certain level of experience to make sure that you get it as a reliable result as possible. One of the limitations is the possibility of a false positive reaction. So previous BCG vaccination, BCG stands for Bacille Calmette Guerin. That is vaccination for TB that used to be used in Trinidad and a lot of other countries, but it was found not to be extremely helpful, other than possibly in children in high prevalence settings where you see lower rates of dissemination and lower rates of TB meningitis. So in a lot of countries where there's a low prevalence of tuberculosis, the vaccination was discontinued because what will wind up happening is that you will be given the vaccine that will actually cause you potentially to have a lifelong positive PPD reactivity without significant evidence of benefit in a low prevalence setting. In some high prevalence settings, it's still done, right? You can also get a false positive reaction, as I said, from incorrect technique. If the person gave it in the wrong place or instructed the patient incorrectly. And a non-mycobacterial tuberculosis infection. So as I said, there are lots of mycobacterial organisms, some of which is not mycobacterial tuberculosis, but share some of the same type of antigens. So you would get an immune response overlapping, but it's not TB. It's like yours, for example, and Pinta. No, sorry, that's I'm thinking syphilis, sorry. But some of those other mycobacterial diseases. False negative reactions you can get with immunosuppression, what we call cutaneous anergy. So any form of immunosuppression, including HIV, but for example, somebody who is on steroids for a long time, or anti-rejection drugs because of solid organ transplantation, would potentially have a negative reaction. Overwhelming TB, because TB in and of itself is immunosuppressive. Because it is so debilitating, it can actually weaken the immune response to the point where someone who has, this TB everywhere, and I've seen a case like that, a TB in the lungs, in the spleen, in the pericardial effusion, the bone marrow, the TB everywhere, and they were negative, but the PPD was unreactive because there was just too sick to mount a response. As I said before, recent tuberculosis in the first 8 to 10 weeks after initial exposure can also cause a false negative reaction response. Recent live vaccination, so measles, for example, right, can cause a false negative reaction. So if you're doing a tuberculin skin test in someone who's getting vaccinated for measles, for example, you can do it either on the same day of the vaccine or 12 weeks after, not anywhere in between. And any uncertain intercurrent viral illness like measles and chickenpox can actually cause a false negative reaction. One of the other limitations, and we see it all the time, is that patients just don't come back. So if let's say we do the skin test on Monday, we ask them to come back on Thursday. If we do it on Tuesday, we ask them to come back on the Friday. And a lot of times, they just don't come back because again, they're busy, they forget. And the result will be invalid if read anytime after that 72-hour window. So the other immune-based screening test is actually a blood test. It's called an interferon gamma release assay, or IGRA. There are two assays, quantiferin gold and T-spot, and it relies on measuring either the amount of a certain substance released by immune cells called interferon gamma in response to the tuberculosis antigen. So the basis of the skin test is inject the antigen under your skin. If your immune system reacts, you get a swelling and a redness, and that's evidence of immune reactivity. This is done in the lab, where you expose the person's blood with the immune cells, in the blood of course, to those antigens, and you measure the amount of response you get, either how much of this compound called interferon gamma is released, or you count how many interferon gamma producing cells are recruited in response to the tuberculosis antigens. The benefits of that is subjective. Right? If you get a response, this much is positive. If it's between here and this, intermediate, if it's that, it's negative. There's no subjective interpretation. Right? The person does not have to return in 72 hours to get their result. You can inform them over the phone if necessary, and you get results typically in 24 hours. And it is not affected by previous BCG vaccination. The limitations is that it is more expensive. Right? So there was quantiferin gold assays in Trinidad several years ago, but it became cost prohibitive, unfortunately. So we're back to doing tuberculosis skin testing. Additionally, it requires laboratory infrastructure. So in some low and middle income countries, they can either afford the cost or the lab setup. Right? And it has some of the same limitations as the tuberculin skin test, because remember, both are immune-based tests. You get reduced accuracy in immunocompromised persons and reduced sensitivity in persons who were recently exposed to tuberculosis. And that's it in a nutshell. So this is just the early taster. So next session we'll be doing more of the clinical stuff, because I didn't think I could fit both into one session because we've already gone into half an hour. So we'll stop there. Are there any questions or comments about the presentation? Don't forget to unmute yourself. And if you can't speak where you are, you can always type in the chat box. Okay. All right.